Welcome, everybody. It's 12 o'clock, and we're going to start right on time here. I'd like to welcome everyone. First of all, I'm Don Tapscott. I'm the executive chairman and co-founder of the Blockchain Research Institute. And I'd like to welcome everybody to this webinar on the next era of healthcare delivery. The webinar is one in a series of webinars, almost weekly webinars that we've been doing at the Blockchain Research Institute. And we've got like over 500 people attending this webinar and a terrific panel. So let me sort of start things off and set some context. The webinar was really inspired, if you like, by a report that we at the BRI wrote for the Biden-Harris administration. And the new administration arrives at a unique time in history. The pandemic has exposed and exacerbated all kinds of problems in the country, in our systems for business, like supply chains, in our economy, and at all levels of government. And this is creating a demand pull for some big transformations. And that pull is meeting up with a technology push as we see the advent of what we call the second era of the digital age, with the trivergence, as we call it, of artificial intelligence, the Internet of Things, and blockchain, the underlying technology of cryptocurrencies. And this innovation of technology push, combined with the demand pull, is really moving us into a period of big change. And in the report, we outlined 5 big areas where the US federal government needs to make almost 180-degree turn. And hopefully that this will be an inspiration for other governments in the world as well. The turn is, first of all, and we identified this as the first challenge, is about data. All our digital identities, we create this data, not just transactional data, but health data, data and locational data and educational data, and dozens of classes of data in our digital identities, but they get expropriated by big digital conglomerates and others. And we argued that America should be the first country whereby citizens can actually own their digital data, and there's a role for government in helping make that happen. Secondly, we argued for a turn on digital currencies, that the current attitude in the United States towards these currencies was problematic. Third, we argued for the creation of a domestic digital Marshall Plan to reinvent the systems of government, as the US federal government has technology that locks it into old models of what is government and how government should operate. The fourth area is we argued that Biden and Harris, including personally, can use this technology to help build a new, more interactive model of democracy, as opposed to what the previous president did, which is to use technology to reinforce an old model where you vote, I rule. And through Twitter and other devices, the former president communicated his views and other things out to the population. But now there's an opportunity to engage citizens more, and in doing so, to rebuild trust and the legitimacy of democracy. And the final one is, obviously, we need to rebuild the economy, and not the industrial age economy, but an innovation economy. And to do that, technology will obviously be critical, but it needs to be done in a way that's inclusive, because minority and other groups have been hurt disproportionately by the pandemic. So we need to take a whole number of steps to build a true innovation economy. Now, today we're going to look at all this through the lens of healthcare in the United States and abroad, looking at how the different players, including government, regulators, legislators, innovators, can come together to really reinvent healthcare for the digital age. Healthcare data, healthcare supply chains, healthcare delivery. And there are a number of topics that hopefully we're going to get into. So rather than reviewing those, I think I'll just kind of get directly to the panel. So we have a great panel today, of which I am a member, and I'll be doing my share of talking, as I am wont to do. Um, and we're also at the end, we'll spend some time answering your questions as well. So do submit your questions in the chat. And we're going to end sharply at 1 o'clock. So our first panelist is Pradeep Goel, and Pradeep is the founder and CEO of Solve.Care, one of the members of the Blockchain Research Institute. And he's got extensive experience in healthcare um, and other areas. And before taking the reins at Solve.Care, he led a whole number of innovative technology companies with various executive roles over 25 years. And Pradeep's been passionate about designing and building solutions for public programs. And he's also built 4 healthcare IT companies and taken them to the top of Deloitte's Technology Fast 500. Pradeep is also in the rankings as one of the 100 most promising entrepreneurs worldwide, as compiled by Goldman Sachs. I'd also like to invite David Randall, Dr. David Randall, PhD, who currently serves as the executive director and the resident scholar with the American Research and Policy Institute in DC. And David has extensive experience as a former top insurance regulator, legislative staff member, healthcare lobbyist, consultant, executive with insurance companies, and trade groups. And he's testified before the US House and the Senate committees of Congress on a variety of health policy issues. And he's right in the center of these big, tough issues. And he's also has over a couple of dozen peer-reviewed professional publications, as well as book chapters on health information technology, healthcare entitlements, and the policy process surrounding healthcare reform. And last, but actually not least, is Gerard Dash, who's the founder and executive director of this amazing organization called the Government Blockchain Association. They have 120 government blockchain chapters around the world, and about 50 working groups, if you can believe it. He's developed blockchain training materials that cover most of the established blockchain protocols, platforms, and products. And Gerard speaks all over the place, including at the United Nations, delivering keynote addresses to audience of thousands of people. He's advised national government, cabinet officials, as well as state and local leaders. And he's actually right now leading a project designed to use utility tokens as transition elements of the GBA into a decentralized autonomous organization, or DAO. And happy to talk about that if you want. And so this project has been received a lot of media and so on. So just to kind of set things up, today we're going to take a broad perspective on the challenge of health. Most of the big debates on this topic are policy debates, at least are, well, they're pretty traditional. They're pretty narrow from my perspective. They focused on issues like funding, you know, and whether or not it's sensible or achievable to have a single payer, like exists in other advanced countries, or principles, you know, is healthcare right? And of course, the pandemic currently dominates much of the discussion. We've got policy issues around everything from masks to lockdowns, getting out the vaccines, tracking immunity. You know, is that a requirement to have safety in the country? Or is it a violation of civil rights, creating, you know, 2 classes of citizens? We may touch on these issues, but we'd like to talk about healthcare in the context of the transformation to this second era of the digital age. And just a personal comment, I wrote a very good book that very few people read in 2012. It was the sequel to Wikinomics, and it was called Macro Wikinomics, worst title for a book ever. Anyway, but it's one of my best books. And in that, we talked about the end of the industrial age. And we went through a dozen different institutions, and one of them was healthcare. And the industrial age is really an age of scale and standards where someone has power at the top of an institution, a company, a government, whatever, and they transmit value one way. So they push out products, they push out services, advertisements, TV shows, education, lectures, government services, and so on, to relatively passive recipients. You know, I'm a teacher, I have knowledge, or a student, you don't, get ready, here it comes. Well, in some ways, and I am being stereotypical here for emphasis, or I'm exaggerating for emphasis, but the healthcare system really is based on that model. You know, I'm a clinician, I have knowledge. You're a patient, you don't. Get ready. Here it comes. And I'm going to deliver healthcare to you. And you only get it, by the way, when you're in the system, which is why it costs so much. And please don't go on the internet and try and find out information, because it's full of all kinds of bad information. And by the way, we're going to collect all this data about you, but we get to own it. And you don't even have access to it, let alone be able to own it or monetize it or use it to plan your healthcare or keep it secure or whatever. So if you stand way back, there's some very significant changes that need to be made to move us towards a more patient-centric, or forget about patient, citizen-centric model of healthcare that's highly personalized, and where citizens are deeply involved, not just in their own health, but more broadly in their own wellness. And then if we're going to do something like that, we're going to need a whole infrastructure of technology to deliver it, supply chains for delivering a product and patient care and so on. So that's sort of my bias bit. But let's move to David, who's someone, that's my view as a sort of amateur. David's deeply involved in this. And David, could you just talk to us a bit about what you think is wrong with healthcare today? And what are some of the growing pain points, if you like, for health delivery and patient care?
Sure, Don, thank you. Appreciate being a part of this group and this panel. So that's sort of a loaded question, but I'll draw upon some of my published research and obviously what I've learned through my experiences professionally as well as an academic. First and foremost, one of the key drivers that has motivated me to look at both blockchain applications within the healthcare system, specifically in the United States, are the administrative costs. So various academic studies over the last decade peg that number at conservatively 20%. Some have pegged it at close to 30%. Needless to say, in the US, we are among the highest in terms of administrative costs. Why is that? Well, there's a variety of reasons for that. Most notably, we've got disparate IT systems. We have interoperability issues that I think are very well documented. I've written somewhat about that. Most notably within the government healthcare space, specifically within the VA and the VA systems, where they've spent billions of dollars attempting to achieve interoperability. The current wave of technology, I think, is attempting to address that, but that's certainly a key pain point, at least in my judgment, what I've written about, that blockchain, I think, can help to address inefficiencies there. Next, I think that one of the key pain points that doesn't get a lot of attention, and that's fraud, waste, and abuse. So one of my published peer-reviewed articles specifically look at the Medicaid systems and specifically how much fraud, waste, and abuse is there within Medicaid systems generally. Through a very extensive claims data set analysis that my colleagues and I utilized and had access to in terms of applying predictive analytics, predictive modeling, we found that that fraud in the Medicaid system, and this certainly translates into other government and to a certain extent private healthcare systems, 16 to 20%. So in my judgment, blockchain technology, blockchain applications can help to address many of these noted, documented inefficiencies within the system. And I know that Pradeep, a good friend of mine, and just in terms of full disclosure, I do serve as a strategic advisor to the Solve.Care Foundation, gladly. And so he's building, I think, remarkable products and solutions that attempt to address those specific pain points. So that, in a nutshell, I think are some of the reasons why blockchain and distributed ledger technologies can assist in alleviating many of the inefficiencies that currently exist within both public programs as well as within the private insurance market.
Great. I mean, one of the challenges here, of course, is that healthcare is connected to everything else. So, overall, and consider the pandemic, it's connected to the big challenge of supply chains in society. How can it be that we couldn't get a paper mask to a frontline worker? Or, why do people hoard? It's got something to do with the problem of the supply chain, not just that the supply chain's having trouble delivering toilet paper, which it can deliver, but more if you have opacity and fear, that leads to certain kinds of behavior. If you know that the supply chain is going to deliver toilet paper tomorrow, you're not going to buy 3 years of it. So it's a very sort of old school industrial age, inefficient, sort of serial model of the ways that things move around. Did you want to comment on that, or?
No, not really, but I will give one example that I think demonstrates how blockchain applications can really attempt to deal with inefficiencies within the system. So a little known program within state Medicaid programs known as non-emergency medical transport. If you've seen cab companies in any major city, they are probably transporting Medicaid patients to and from provider appointments. Part of the research that I did looking at NEMT that has been published, we estimated that the fraud within the NEMT system within state Medicaid agencies is between 25 and 30%. Why is that? Because frankly, a lot of states are operating with push pins and maps on boards in terms of coordinating this on a county by county level. So I think that is a perfect example where if you had a blockchain application to deal with this inefficiency in terms of how it's scheduled and patients missing appointments, where you could have a documented chain and interoperability among providers, you could eliminate, close to $1 billion worth of unnecessary payments out of a $5 billion program that states are currently administering.
Okay, so Pradeep, that kind of sets you up. I mean, Solve.Care, pretty interesting company. Why don't you begin by just commenting on what is the problem, and then tell us a bit about the Solve.Care platform and how you've got different components of that platform that are attempting to address these problems.
Thank you, Don, and it's a pleasure to be here. Thanks for the introduction earlier. So in terms of the healthcare, I have had the chance to look at it from different angles as a parent, as a patient, as a health IT exec, as a government program administration and implementation responsibility. And one thing that you do realize is that healthcare is very local and very complex. And there are as many solutions as there are people, and everybody is bringing a different perspective. So no one solution is going to work across any large segment of the population. But what is important to recognize is that there are certain commonalities in the issues. And you mentioned a couple of them already, and so did David. One is that we build processes first, and then we hope the patient will participate in them and the doctor will participate in them. So I think healthcare is uniquely non-patient centric. It's process centric. It has always been process centric. And those processes are established by entities other than patients. And patients simply participate in that process somewhere along the way. And that is also true for doctors. They don't design these processes, they simply follow them, which has a unique effect of disenfranchising the two most important people in healthcare, those who need care and those who deliver care. And neither one of them are involved in designing the systems they have to use to deliver or receive care. So patient centricity has been long talked about, but rarely achieved because they have no role to play other than to be the beneficiary of the healthcare system. And the provider is nothing more than a provider of healthcare services. I, as an insurance exec, decide when they get paid, how much they get paid, who they can see, what network service they can offer, what requires pre-authorization, what requires referral. So you see the processes are very long and complex. And as a patient, I get to have the privilege of participating in some obscure step along the way. It's a very difficult equation. It's not easy to change. And I think the role of the government, if you go back to that, if you're going to make patient-centric world ever come alive in the healthcare sense, then you have to give some power to the patient. You have to recognize them as not a beneficiary of healthcare, not a recipient of healthcare, but an active participant. So that's the philosophy. It's going to take a while to achieve that, but it's going to require more than technology to get there. Having said that, the role of Solve.Care is to make a more relationship-driven healthcare possible, where we can put the patient in the center and design care models around the patient rather than process-centric model. And I'll give you a simple example. And I was previously at an insurance company, and we laid out, at one point we had a design room, and we laid out a left to right process of how you sign up for my plan, my health plan, my insurance policy. And that process, when pasted on a paper, covered the entire length and breadth of my room. So it was a long process that had multiple steps, and you have internal, external steps, and it was probably 200 steps. And I could never, ever understand how enrollment system works under my watch, because it's so complicated. That was one of hundreds of processes that my IT systems managed. And patient had maybe 3 steps along the way that they would participate in. Step 1, step 67, step 193. Everything else was managed by a bunch of other processes. That doesn't work, because in that model, what we are doing is we're making healthcare extremely inflexible. Changing that business process flow that I had printed and stuck on my wall would cost millions of dollars. So naturally, I was resistant as a CIO to make any change to that process. We need to look at healthcare delivery differently. Healthcare is continuously evolving, and it's continuously needs to evolve faster and more to the patient-centric view. So that brings me to Solve.Care. 30 plus years of building IT systems that look very similar to the previous system that we replaced for hundreds of millions of dollars worth of cost wasn't going anywhere. So that the notion of Solve.Care is, let's reimagine healthcare on a relationship model. Let's imagine healthcare where a patient has relationships with their doctor, with their specialist, with their family members, with their church, with their community, with their government, with their employer. And those relationships can be individually configured and reconfigured rapidly. And each relationship is on a blockchain, so it can be audited. It can be measured for its legal, regulatory, and functional compliance. And we can then allow the patient to be the interoperability hub. Wouldn't it be great if the patient was the hub of interoperability, not some obscure system in the cloud or some bunch of systems who are talking through some service-oriented architecture, but if everybody published and received their data from you and I as patients? Because our data is our health. Who else has more interest in managing your own health than you and your family? So our vision is that if fundamental disruption is needed, which is both economically more effective for the administrative organizations like insurance companies, government agencies, is far more effective for the providers in delivering care, and it's way, way, way more effective for the patient. So what we basically did is we said, let's take these linear processes and let's turn them to circle around the patient. And let's put the patient in the middle of a process-centric relationships, rather relationship-centric processes versus processes that I'm supposed to join. And that has brought an incredibly disruptive viewpoint to healthcare. And wherever we have gone and launched our solution, we have been able to show significant savings and significant acceleration of engagement and access and outcomes, things that matter in healthcare.
Well, it's a radical idea, isn't it? That the patient or citizen should be at the center rather than the process or the system. And go ahead.
No, you're absolutely right. If I may just add that, our view is that the patient owns the data. This is patient's data. You want it, you go ask for it and you go get it. So as an insurance exec, instead of me controlling your eligibility and telling you what doctor you can go see, I want the doctor to ask the patient, am I eligible to take care of you? Are you eligible to pay me? And that interaction should happen between the two of them, between the doctor and the patient. I, as an insurer, can send my eligibility data, publish it to the patient wallet, let the patient decide who they want to share it with. I don't need to be in the middle of the traffic cop between doctor and patient. And that is true in hundreds of other scenarios. So yes, the fundamental premise is patient is autonomous, sovereign, and capable of making decisions. And you got to give them control over their data. And if you want it, go get it.
All right. Well, we're going to come back to that because I think you're right. Data is really at the heart of this. And it's the asset class, really, of the healthcare system and of the digital age. And we created, the data is created by our bodies and by our health or lack thereof, or by our actions with medications and so on. And increasingly real time, that our heart rate, and it could be in a pandemic, our temperature or anything else, we create it, but it gets expropriated by all these different players. And that's a whole bunch of problems. It means that we can't use the data to do the kinds of things that you're talking about, to manage our own health. It means that the data is probably not secure because it's on a central server. And there are two types of these servers, those that have been hacked and those that will be hacked. It means that we can't monetize the data. Maybe you want to anonymize that set of X-rays that you've had and sell it. But other people are taking advantage of that. It means that in, say, a pandemic, all this data is buried in silos, so we can't aggregate it together for any kind of social or health purposes, societal purposes. And of course, our privacy is being undermined too. And people say to me, well, Don, privacy is the foundation, or privacy is dead, get over it. If you got nothing to hide, what's your problem? I think this is foolishness, because without privacy, you can't have freedom. And so we need to get our data back. And that's a very exciting mission that you're on. And I know you're itching to say something, but let me just go and we'll introduce Gerard into this conversation. And Gerard, it's very handy here. We're getting tons of good questions. So rather than me asking a question, I'm going to refer to a question that came in from Mark Haddle. And he says that healthcare is a huge landscape with disparate platforms and a menagerie of data taxonomies. Most data sharing is through EDI or old-fashioned facts. And given that blockchain can serve as a unifying medium, why do we encounter such headwinds with adoption? And how can we engage the forces that can affect innovation? So there seem to be some pretty clear opportunities here to not just to use technology differently, but to reinvent the whole model of healthcare around this technology. Yeah. And you're in the heart of government trying to make blockchain happen in government. I mean, what's your sense of the openness to this and the landscape and the sort of even the know-how amongst government leaders to be able to embrace these ideas?
Well, Don, I appreciate the question. There's a lot of different ways we can go. I do want to thank you when you said I was in the heart of government and you didn't say the belly of the beast, right? And just as a little sideline, I was sending a message out to a large number of civil servants, and I really love autocorrect because it actually autocorrected right before I sent this out to hundreds of civil servants. It autocorrected to civil serpents. So I had a little bit of explaining to do.
At least I didn't mess with the word civil.
Right. Yeah. So I'd like to talk about a couple things, and you talk about reimagining. I'd like to talk about paradigm for a second, because if you think of blockchain, right, and where it came out of, right, it came out of this concept of let's decentralize, right? We have these banks that are too big to fail, and the whole genesis, even going back to 1991 up through the Satoshi white paper, it was all about decentralization. But when we think about solving these problems, many people automatically go to the centralized authorities, right? And we're not even actually embracing our own paradigm in how we want to approach the problem. And so I'd like to maybe just share with you a couple stories about how I've seen other people broach the problem, and then really talk about the importance of interoperability. Because if we go to the top and try to standardize, right? And Don, by the way, your report was fantastic. I would encourage everybody to read it. I think that we definitely need a top-down and a bottom-up approach. So what I'm saying is not opposed to that. It's essentially in addition. But one example is, in fact, I think Ann Ingram is on the is in the group here. She's got a project called the Healthcare Delivery Blockchain Platform. And so their approach was let's solve a particular problem. And going back to Pradeep and the data, right? And everybody should own the data. Well, they went to folks that don't own anything. They went to the prison population, and they said, look, we got a specific problem to solve, and that is there's mental health issues associated with recidivism rate of inmates, right? And that's in large part because their behavioral health issues are not properly diagnosed, they're not tracked, they're not treated. And so they said, listen, let's come up with the idea of creating a health information exchange for this particular population, right? And let's engage with not just the healthcare clinics, but also the correctional facilities, the police, the social services, to create this holistic response, right? Again, you got disparate databases, but they're trying to solve a common problem. And they didn't go to the national authorities. They basically went to state and local, right? And when they started peeling the onion back on that, then they found folks in correctional facilities in other states and other educational institutions. And by focusing on solving a particular healthcare problem, right, they're in the process now of expanding that up and out. And one of the things I think is really fascinating, if you look at Bitcoin as a consensus or as a governance model, right, there's no division of Bitcoin, right? There's essentially this broad-based community that they kind of decide on what the protocols are, and they vote on it, and it creates this natural consensus of things that make the most sense kind of coming together. And at the end of the day, the best ideas win the day. So the first thing that I would say in terms of how do we engage with governments is let's not go to the very top and try to come up with a standard that everybody's going to agree to. That's old paradigm thinking, and I just don't think that's the way to go. Now, that doesn't mean you shouldn't go to the top, right? Oki Mek, who's a chief artificial intelligence officer, I want to go to supply chain, Don, because you talked about that and the importance of it. What they did was Oki Mek had a project called Accelerate. In fact, I will drop into the chat a video that he did. This is not. Let's see. Did I drop? Oh, sorry, I dropped the wrong place. Well, I'll get it in a second. Here we go. So he and what's the guy? Jose Arrieta. They put together a project using blockchain and AI, where they said, look, let's look at how HHS acquires products and services, and let's put AI on top of that to sort of scrub the data and just identify the anomalies between this department paid X and this department over here paid 2X for the same product, right? And if you can watch the video that he did for we have an AI and government group. They saved HHS $30 million, right, by simply looking at the existing acquisition of products and services for the healthcare, putting a layer of AI on it, and then essentially writing all that to blockchain. They had to aggregate, I believe, 30 separate contract writing systems, right? And then the last area, and again, so my message is, don't try to solve the entire big problem. Solve these little ones, right? Right after the pandemic, everybody went to track and trace. And I had tons of people come to me and say, hey, let's get involved in this track and trace project. And I was like, you know, everybody in the world is racing after that one problem, right? And I'm like, I don't want to go there. But let's think about tracking. Think about the pandemic and how we got out of it, or how we're in the process of getting out. And you have to look at operational warp speed, right?
All right. So let me just pick up another question here that I think will
Oh,
help
yes, sorry.
move this along. And Pradeep or David, feel free to comment on this. So hang on here and I'll just find it. So if we could begin with a healthcare use case that addresses interoperability. This is from John Ferrer. Interoperability to bring value of blockchain technologies to solve data reconciliation across systems. Would you begin with a provider directory, claims adjudication, or clinical reconciliation? Pradeep, do you want to comment on that?
Yeah, and thank you, Don. And it's a great question. The answer is they are not mutually exclusive. Let's take each of them very quickly. Provider directories are a perennial challenge, maintaining them, keeping them up to date, having them be reliable, and they are useless if they're not linked to availability. You can have a list of doctors where you call 93 of them out of 100 aren't available because they don't accept new patients, they don't accept your insurance, whatever. So I think the providers are the most up-to-date information sources of what they are willing to do and who they're willing to see and what insurance they are accepting as of this morning. So having a blockchain solution where the providers can elect to publish their data securely and control it with appropriate authority and have it be usable to patients is obviously a easy use case and not easy to implement, but a logically understandable use case. And we are effectively doing a use case almost exactly that today, allowing for a global telehealth exchange, as we call it, where physicians can elect to publish their data, control every element of it, their qualifications, their education, their availability, their rates, their ability, the eligibility requirements they want to have the patient meet, everything. And the blockchain doesn't serve so much as a data store, but rather as a control mechanism to link the patient and the doctor with each other. Because I don't think that blockchain is a very efficient data repository. It's a very good control mechanism. It's a control layer. It's a wonderful way to know what was done by whom, when, and what authority was given and what consents were revoked. It's a great consent layer. So doctors, patient, provider repository, absolutely, provider directory. Let's look at the care coordination. We built a care network around clinical care coordination and matching your actual care against optimal care protocols. So we built something like that in partnership with a very large pharmaceutical company around adult diabetic patients at risk of heart disease and stroke and death. And the model was very simple. Your care, but very difficult to implement, but still was successful in that you publish the optimal care model, be it ADA approved or be it American Heart Association approved, or whatever the regulatory body is that governs the quality, because there's always going to be an independent authority whose model we want to follow. And it allows the blockchain to compare the actual events in the patient's life against the care model and identifies care gaps. Hey, you aren't getting your A1C checked every 3 months. You haven't had an ophthalmology exam in 2 years, whatever. And that allows the patient to have actionability. Then you match it to the provider directory, and now you have access to care. So it's a very good use case that Mark has just raised. And when you look into claim adjudication, I would submit that we shouldn't be adjudicating claims anymore. We should be authorizing the patient to essentially get services according to a pre-approved programmable authority token that I can send to you as an insurer, and you can spend it on any doctor. If they'll accept it, I'll pay them. Why do we have to maintain all these silly things like preferred networks and provider contracts and secret rate sheets and annual negotiations? And David has done enough of those oversights as an insurance commissioner to know that it is madness. In the end, it doesn't lead to better care, better results for the patient, or better cost savings. It doesn't accomplish anything. So why don't we delegate the authority of the payment to the patient and say, this is what my authority is worth. I'll pay $52 for an E&M visit. As long as a physician is a certified physician, you want to pay an $80 case, go pay it. 28 is out of pocket. 52 is going to be a fungible token from my side. We don't need to do this pay and chase or service and bill and wait and get paid and appeal and reappeal and finally get paid 62 cents on the dollar 180 days later. So we can reimagine claims adjudication as authorization that is given, and the patient can simply access that. So, but yes, if you wanted to do the current model of adjudication, you can use blockchain as a proof of care having been given by the right person to the right patient. And you can certainly optimize that too. But I would argue we should get away from this adjudication model altogether.
Okay, sorry, go ahead.
I couldn't agree more. So if we look at some of the pain points within the system, waste, fraud, and abuse, some of it is obviously tied to these arcane adjudication processes that are currently being developed. So I think what Pradeep outlined very succinctly is that setting this up on a blockchain and having it tokenized under a smart contract can very specifically deal with some of the waste, let alone fraud, that's occurring within these processes.
Yeah, and if I may add just one more thing, Don, I'll hand it back to you. You know, using the transportation example that David gave, there is a lot of black market for transportation vouchers. There's a lot of administrative cost in making sure that the patient is actually going to see the doctor for this paid for trip. There is no reason why we can't, and we have already built a solution around NEMT, which essentially allows the transportation to be tokenized, Uber, Lyft, whatever, taxi driver, and the payment authority is given to the patient as long as the pickup and the destination are pre-approved as part of their profile. And the consent's granted by the government or by Medicaid on the chain, so any taxi can pick you up from the designated place and take you to your designated place. So integrated model where we demonstrate that fraud simply disappears. There is no way to game the system if the pickup and the destination is preordained based on who you are and your identity. But one last thing I'll say is a lot of blockchain solutions that are being imagined or implemented depend upon one fundamental premise. That's the identity of the patient and the doctor. So we are going to have to make sure that if government is going to step in, that they do allow and permit for an identification mechanism on which all these solutions can function. And we can transform a lot of things. But without a decentralized identity model, and if we're going to end up with a bunch of identity systems, Medicare identity, Medicaid identity, Blue Cross identity, Mayo identity, Hopkins identity of me as a human being, then it's going to be very difficult. So I think a underlying premise here is that the identity problem has to be addressed. And there is a regulatory responsibility here. Because without that support for that decentralized identity, all these beautiful systems that are being imagined and implemented are going to struggle with proving that John Doe and Jane Doe are who they say they are. So I think that's a challenge we still have to
And
overcome.
Don, if I could leverage off of what Pradeep just said, because there's a two-part question about the directory and also clinical trials. I think that again, if we look at the process that we just came through, right, and how we got to the vaccine by lots and lots of companies working on this problem together, right, which is a great model, but it was enormously expensive, right? And if we look at the use for blockchain in the area of clinical trials, and you know, can participants in clinical trials have their data anonymized such that it's available to lots and lots of researchers? You know, one of the big problems with research is the cost, right? And I've always been a big proponent of public, you know, like the NIH, public research and then private capitalization of you know, once it's commercialized. But that's not the way we do things now. So if that's the case, then researchers have got to be able to figure out how they can share their data, their information, their findings, and capitalize on their work, right? So because what we just came through is the government just said, look, we'll pay for everything, just do whatever you have to, we'll totally absorb the cost. And again, got us a vaccine, but at incredible cost. And so if we could develop a ecosystem in the clinical trial space, right, where findings and data can be tokenized such that these companies can share revenue and opportunities and also connect with participants, right, so their data can be shared. And again, this COVID thing was not a US or a China or a Russia thing, it was a global thing. So we really this needs to be a solution on a global basis right? It can't be done on a one country, or you can't be Canada and the US. We've got to be able to come up with a tokenized ecosystem in the clinical space. It's not that would reduce fraud, but I think would bring the cost of healthcare down tremendously.
Okay, so let's talk about that. Some obvious big opportunities here, but how do you make it happen? I think it was you, Gerard, that said it's not necessarily top down. Um,
It's not only top down.
Yeah,
Right.
yeah, and I think that that's right. I mean, it's top down, it's bottom up, it's diagonal, it's sideways, it's corkscrew shaped. It's like every possible way. But maybe David and Pradeep, do you want to talk about that? I mean, it's true, of course, what Gerard has said. Ultimately, there should be a standard platforms and models that would work on a global basis. That's probably not going to happen in the next, couple of months. And it's probably not going to happen in my lifetime, but how do you get from here to there? How do you create the condition whereby when a government makes new investments, they contribute to a desired future, as opposed to perpetuating the legacy?
I'll start. I honestly think that specifically in the US, and I think this is applicable to government-run systems in other parts of the world, that this is going to have to be incremental. We're going to have to take this one processes, one state Medicaid agency, one group of providers at a time, and I am of the hope that this will then build momentum in terms of dealing with a system that is truly interoperable and is a lot more efficient than it is today.
Yeah.
Yeah, this is, so my perspective is that we need to make it easy to solve the low-hanging fruit. So the position I've taken, and because I come from an IT, health tech, benefit coordination, care coordination background, is that we need to make it easy for people to try these new concepts. Let me say three things. Blockchain as a technology is not easy to use. Building an application on blockchain that is a single purpose application to solve a specific problem is a meaningful investment. But building any kind of a digital network where multiple parties participate and solve a complex coordination problem, be it benefit coordination or clinical coordination or payment coordination, is 1,000x more complex undertaking in terms of cost and time and skill and domain expertise and technical investment and risk that goes into building these. So the position we have taken is that blockchain's properties are valuable, but blockchain isn't a business-friendly environment. Nobody can say blockchain is just designed for rapid application or process delivery yet. So the position we took is let's build a platform that is a full stack platform that has blockchain-like properties at all levels: application, data, security, consent, permissions, business logic, process definition. And yes, blockchain should be somewhere inside it, but you shouldn't have to learn blockchain to do blockchain. So in that scenario, the view is, if in my old chair as an insurance CIO, somebody brought to me a platform like Solve.Care and said, listen, Pradeep, you want to solve the specific problem of provider registry or claims payment delays or appeals management or network management, whatever. And you have every insurance organization, every hospital, every clinic has their own set of challenges. We need to make it easy. So our vision is very simple, and it's not easy to achieve, but this is the simple statement. You need to be able to design a blockchain-centric process which can be circulated across multiple parties in the span of a day, a week. A month is too long, so that you can test what works. You can run a decentralized application between doctor, patient, broker, insurer, employer, and see if the value proposition is there for all your chronic or your multi-chronic population or your pre-chronic groups or your healthy and wellness group, whatever. And the point here is that a platform like Salesforce.com, but with blockchain properties, will help us do this bottom-up thing. Now, top-down, we got to have the government support certain things, starting with mandating that the patient owns their data. It's not just about, we don't need to move the data into some central repository. We don't need to have some big, huge data warehouse for each patient. Data can be across multiple systems, but the consent to use that data should be in the hands of the patient. They should have access and ownership of the data, even if it's sitting in Epic or Cerner or all scripts or my adjudication system, data ownership has to be with the patient. And that blockchain can do very well. What we need is a regulatory support. So the bottom down, top down is empowering the patient through regulation. The bottom up is having a platform like Solve.Care and many others will come eventually to make it extremely easy to launch decentralized applications, relationships, and full-blown networks on using the blockchain properties. And when those two collide, we will transform healthcare. And one last thing I'll say is to my team, I say this all the time to them, guys, the journey we are on in Solve.Care probably will not finish in my lifetime. You, the next generation, and the one after that is going to carry this torch for a long while. But we're going to put the foundation in now. We're going to make sure that on our platform like ours, people will transform healthcare. And it's kind of like the old legend, I don't know if it's true or not. Somebody asked Steve Jobs when they were building the App Store, why don't we build the apps? And he said, we are smart enough to build the App Store, but not smart enough to build the app. Some kid in Vietnam will change the world in a manner that we cannot imagine. Now, whether it's true or false, it sounds right. And my view is we need to empower change. We need to put a platform out there that makes it easy for a doctor to reimagine the way they do practice medicine without becoming a blockchain expert, which they're not going to become. And we want to reimagine the way family members want to take care of their sicker members of their family without having to become blockchain experts. So this notion that we empower people to take better care of themselves as a patient, as a doctor, as a broker, as an employer, even as the bad insurance CIO, I think that's that's our mission that we build. We launched the Salesforce.com equivalent of blockchain empowered healthcare system and let the world then choose the solution they want to bring. But I think government has to play a role because they have to allow the patient to be autonomous and empowered.
Okay, so we've got 8 minutes left. Just a ton of great questions. I've picked up some of them. First of all, on the screen here, that's the cover of the report. It's a massive document. We're very, very proud of it. You can find it at our website, blockchainresearchinstitute.com or .org, blockchainresearchinstitute.org. Go there and it's free and have a look. So let's start with Jay Graven. And he says that the patient is not party to ownership of his or her own medical data is fundamentally flawed. Having the right to request one's record is hardly equivalent. Are there any healthcare blockchain projects with this consideration as a basis of solution? And he goes on, I believe that if we could do this, we could own your data. It would access these core healthcare problems: prior authorization, industrial data pipelines, which exclude any direct benefit for each patient, and thirdly, the inordinate expense for a marginal difference in the quality of care outcomes. 30 seconds. Anyone who wants to respond.
Don, let me throw one out there. One of the things that I think is really fascinating about the healthcare delivery blockchain project that they're doing is one of the very first things that they're doing. They have a Hipaa compliant blockchain, and they're allowing anybody. Well, we haven't announced this yet, but they will allow anybody who wants to upload their medical records to this blockchain. The blockchain is essentially going to be not fully open in public, but pretty close. Essentially, I can't get into the details in 30 seconds, but that's happening. I believe they're working with a company out of London called Earth ID. But that is, if anybody's interested in that sort of a solution, that's the healthcare delivery blockchain platform is one project that I know of that will allow anybody to upload their personal health care data to a blockchain to accomplish that using a decentralized identity.
Yeah. Any other comments on that one?
I will say just this, that I think if we think about patient empowerment, we should make sure that we give patient control over the use of their data rather than trying to put everything in a single blockchain that they would somehow carry around in their phone. When data needs to be shared and data will be spread, right? You can have lab data, medical data in clinical setting, hospital setting, government setting, insurance setting. We simply need to make sure that the patient has essentially a control mechanism or consent layer, which everybody has to seek consent from. And if we simply require patient consent through blockchain, everybody's going to have to publish what data they're holding and where, which means the patient has access to it. We don't need to build some global repository of data on blockchain to use blockchain to make access control for the patient. So what I'm saying is we want to essentially fundamentally empower the patient without having them to first aggregate their life history and their entire care medical journeys. We simply need to require that everybody who is holding anybody's data, be it the doctor, the dentist, the pharmacist, the insurer, has to seek their consent on a blockchain system, which then is immutable consent. Nobody can deny the consent was given or taken away. And you can actually take away consent that way, because on the chain you can give and remove consent. So I think something that fundamental is where regulatory involvement could really help. Technologically, I think blockchain is maturing, or platforms on top of blockchain are getting closer to where business can actually use blockchain capabilities. Because without that, we're just talking about technology, and technology doesn't equate to business value. But as we bridge that gap, I think the regulatory support from forces like yourself at BRI, who are advising governments and advising large organizations of the kind that Dave and Gerard and me were part of in the past, that I think will transform. That's a pivot point, if you could talk about tipping point analogy. I think that evolution of blockchain platforms married to a governmental intervention to empower the patient's rights, we see significant change very, very quickly.
Yeah, I'll refer people to one of the case studies that we did, and it's about the University Health Network, which this was Newsweek just rated as the number 4 healthcare hospital system in the world. It's based in Toronto, and I'm actually a patient there, and I have a thing called My UHN, which is my healthcare record. And when I leave the hospital after an X-ray, my radiology report is there, and I can, before I leave the hospital, actually, I can look at it, I can get it, I can try and understand it, I can use it to talk to my doctor. But UHN did that's on a central system, but they did a project on a blockchain to give patients, as you're talking, Pradeep, the right to consent, to give parts of their healthcare record to researchers to conduct research. And a natural extension of that would be to move this My UHN onto a blockchain, so that when I have that radiology report, I can actually send it to somebody else, get a second opinion. I can anonymize it and give it to science. I could sell it if I want. I could, I could whatever. But the idea is that, as the questioner, I think it was Jay, was referring to, I own my data. And this is not just some kind of abstract principle about human rights or something like that, or you could make that case. This is about moving to this patient-centric model of healthcare. Because how the heck are you going to manage your own healthcare, let alone how are you going to have privacy and prosperity and be able to aggregate data across people in a social crisis like a pandemic if you don't actually have ownership of that data, not access to the data, but ownership. Gerard, we got 2 minutes. Did you have
the last thing, just to kind of pivot on what you and Pradeep said, the key is having a marketplace where, and many blockchains where people can write their solution, and having interoperability between those blockchains, and having these blockchain entities being able to talk to each other, right? Look, it's a big ocean, right? If anybody says, hey, we're going to boil the whole ocean, they're just crazy. And Don, one of the things that I really appreciate about you and your organization is how you bring people together. And I'd like to talk about how we can, in other ways, bring people together to talk about how do we all solve these problems together? Because if we're all building these solutions, right, to boil the whole ocean, if we do it together and can communicate, then we create those interfaces and we create that interoperability that I think is so critical to this space.
Yeah. David, any final words on how we get from here to there? And then Pradeep, I'll ask you the same question.
No, just one final comment. I guess it dovetails on both Pradeep, your comments, as well as Gerard's as well, that simplicity, I think, and usability are the key to making this successful. All we need to do is look at the extreme complexity of the VA rollout of their EHR systems for an example of an overly complex system that really wasn't usable. So I think that in terms of many of the pain points that we've talked about, that blockchain applications used discreetly, used strategically, can help to alleviate a lot of these bottlenecks and inefficiencies within the system.
Yeah,
Pradeep?
and Don, I will build upon what Gerard said. Interoperability is key. We're not going to solve any, everybody's going to add value, be it provider solutions, be it patient-centric solutions, be it insurance or benefits administration solutions. And we have lots of great, enthusiastic adoption, innovators around blockchain and even non-blockchain healthcare solutions that have equal value. What we need to do is really focus on tying them together into a patient-centric usability model. And that really speaks to my view that the interoperability is not systematic. We can't achieve interoperability by requiring every system to talk to every other system. But what we can do is to make the patient the interoperability hub. If we can all agree upon the patient being the real interoperability hub, and we can empower them through blockchain as a control mechanism for this interoperability, and we can publish and receive data from the patient as the hub, we can transform healthcare in a much faster time frame than this pursuit of systematic interoperability. And I've been on the implementation side of interoperability since 2010, as Dave knows, in government and in commercial insurance. That goal is never going to be achieved, where every system talks to every other system and all data will flow freely. That's not the model. The model is somebody has to govern this interoperability. Who is the best person around it except the patient, right? So let's make them the hub through the blockchain as an empowering technology around them.
I think that that's a great note to end on. And this is the new paradigm, if I can use that word. I think some of you have heard me say that I wrote a couple of books in the 1980s that nobody read. But I finally wrote a bestseller in 93, and that was the book Paradigm Shift. It was obviously a big book. And in it, we talked about that a paradigm's a mental model. I didn't invent the idea of a paradigm. That came from Thomas Kuhn, a book called The Structure of Scientific Revolutions in the 60s. But I just applied it more broadly beyond science. But when you have a new paradigm, the mental model breaks down, you get a leadership crisis, because paradigms, they put boundaries around what we think. They constrain our actions. They're often based on assumptions that are so strong that we don't know that they're there. That clinicians control data, or corporations control our health data. And there have been many over the years that the world is flat. That was a paradigm for millennia. And Galileo came along and said, the world is round. The leaders of Newtonian physics had great difficulty embracing Einstein's general theory of relativity, because leaders of old paradigms have great difficulty embracing the new. So that's the big challenge here, is to change this whole mental model. And I thought that the three panelists summed it up well. That when all is said and done, if you think about how to rebuild healthcare for improving outcomes and for reducing costs, 20% of the GDP in the US, we can build a model that's focused on the patient. And the key to doing that is data. And that all of these processes focus on the patient, more broadly on the citizen, as we think about wellness, not just the delivery of health care. And that citizen owns their data and can manage it responsibly for their own health. We've done a ton of work on this area, and I'd refer you all to the BRI site. First of all, this is where it's just blockchainresearchinstitute.org, and you can go and download the report. This is one of many webinars that we've done. A lot of our research is now public domain under a Creative Commons license, and we've spent close to $1 million developing online courses that are actual formal courses through INSEAD, the business school, one of the top business schools in the world, and Coursera, the largest provider of courses. So we encourage you to go there and to check it out. And I'm sorry we didn't get to all the questions. They're just a wonderful group. But I would like to, on behalf of all of us listening to you, to say thanks very much to Pradeep, to David, and to Gerard for a thoroughly interesting conversation. This is to be continued, not just tomorrow, but over the decades ahead. So thanks very much, and we'll see you all at blockchainresearchinstitute.org.
Thank
Bye.
you,
Thank
Don.
Thank you, Don. It's
Thank
been
you.
a pleasure.
Thanks, everyone.